Thank you, Jiaming, for the invitation here. It's really a great pleasure for me to come and kind of talk about what we've been working on and hopefully recruit some talented graduate students to Stanford Cardiovascular Institute because we do have a dearth of talented electrophysiologists. So I'm going to give you a sense of what we've been working on, and some of this may or may not relate to what you're working on, but I think it's also nice for you to see what folks in the other fields are using these iPSLs and also genomics for. So this is my disclosure slide here. And I think for the audience here, you're probably aware that heart disease and cancer, number one, number two, leading death in the U.S. And therefore, whatever you're working on, if you're working on heart and cancer, is probably very relevant. What you may not know is that many of the medications that we take as patients and as doctors are giving out to patients, they actually don't work. And so shown here, for example, I'll take Abilify. Out of 5 people who take the medication, blue means it works, red means it doesn't work. So out of 5 people who take it, it only works for 1 person. You guys are probably not old enough to take Nexium, but for the older folks who take Nexium, out of 24 people who take the medication, only helps 1 person. And so here, it's an imprecise medicine. It's a time for a 1-person clinical trial. And this gets to the President Obama's Precision Medicine Initiative that he set up back in 2015. Here, the goal is trying to deliver the right treatment at the right time, every time to the right person. A lot of this is based on advances in genome sequencing, advances in biomedical data analysis, advances in genome editing. And I'll explain how you can merge these 3 for precision medicine. The next generation sequencing, this is an interesting slide. This shows the Moore's law, which is how fast the computing chip goes, and also the relations to time and the cost. This is the next generation sequencing. Just keep in mind that back in 2001, the patient who got the first patient who got sequenced cost NIH more than $100 million. Right now, we actually send our samples to Korea, and they charge us $850. So it goes from $100 million to $850 within a span of less than 20 years. In terms of genome editing, I think you've heard quite a bit with the genome editing technology with Jennifer Doudna. But different kinds of technology has also evolved quite a bit from ZFN to TALEN to CRISPR genome editing. With the CRISPR genome editing, you could do genome editing in the cell, which is what we do. We do a lot of genome editing in the iPS cells. You could actually, by using AAV virus, you could deliver this. People have done, although quite unethically, genome editing in embryo, human embryo, and they give rise to babies right now. And then the third technology is this iPSL concept, which I'm sure all of you are aware. This was discovered by Shinya Yamanaka back in 2006, 2007. Essentially, you take patients' blood or skin, hit it with 4 genes, you make the iPS cells. These iPS cells, for all practical purposes, are the same as the patient's ES cells. And ESL give rise to you, right? I mean, ESL, your dad's sperm, your mom's egg give rise to embryo. The embryo give rise to you. So biologically, it makes sense. It's not alchemy. And here, we're trying to understand how is it that we could, different stuff that we could add to the iPS cells to make cardiomyocytes. And because it's genetically the same as the patients that we derive it from, we can then come up with personalized precision approach and understand the disease mechanism. So I would say those 3 technologies, the sequencing, the genome editing, the iPS cell, in my opinion, at least for our labs, it helps quite a bit in terms of understanding disease mechanisms and doing this with drug discovery. So, this is a standard workflow that we have at our Cardiovascular Institute. We recruit patients, and we take their blood, isolate PBMC, hit it with Sendai virus, and generate the iPS cells. And from these iPS cells, we set up these assays to study them. And then for this particular audience, because I think you guys are much more focused on arrhythmia, then we could also, from the arrhythmia standpoint, we could do PAT clamp on these cells. We could do MEA. We could do fluorescence imaging, and we could do impedance on these cells as well. And it's really up to your imagination to see what is it that you want to study with these patient-specific iPS cell cardiomyocytes. So we use what we call chemically defined generation of human cardiomyocytes. It's got 3 components. Chemically, it's called CDN3. It's got the basal media. It's got L-ascorbic acid. It's got human recombinant albumin. We like this protocol for our cardiac differentiation for a couple of reasons. One is that we don't use xenogenic products such as FBS. If you use xenogenic products, it's much tougher to go to the clinical trials because FDA would ask you for avoidance of our xenogenic product. It's also less variability in terms of batch-to-batch variability with the FBS. And then for us to make a bottle of this, it typically costs us about $50 to $60. Whereas if you were to buy a differentiation media from Thermo Fisher or from stem cell technology, probably costs you about $300 per bottle. And so we've been doing the differentiation for a while. And so I went to Stanford back in 2004. At that time, we were working mainly with human EA cells, and you can see that here back in 2004, we were able to get about 5% efficiency, and this is something twitched right here, and the problem I had was, these are what a cardiologist would call junk cell. Junk cell just means non-cardiac cells, although a lot of people are interested in these other non-cardiac cell types. And then fast forward 14 years later, 15 years later, instead of using human EA cells, we routinely generate human iPS cells from their blood and differentiate the cardiomyocytes, 90% plus efficiency, very robust. We show here some papers that we have published along the way. And just like many of you guys, we could do 2D micropatterning. This is with Beth Pruitt, who's now at Santa Barbara. And this is a 7-to-1 ratio. You can see the nice sarcomeres. You can see the nucleus structure. And we could do a 3D approach. This is in collaboration with Wolfram Zimmerman, in which a chunk of these human iPS cell-derived cardiomyocytes spike with different amount of fibroblasts, a different amount of endothelial cells. And then this allows you to calculate the systolic force, diastolic relaxation, and so forth. Now, keep in mind that these cells are not the same as adult cardiomyocytes. For example, morphology-wise, they're round instead of rod shape. The electrophysiology, they're higher resting membrane potential, mainly because they have a presence of the funding current. The conduction velocity is slower. The human calcium, the calcium handling is more inefficient. The mitochondria has a lower bioenergetics, and then the response to beta-adrenergic stimulation is also lower. I think it really depends on what camp you are, meaning that whether this is a half full or half empty. Half empty means that these cells are no good. You might just as well stop. Half full means that these cells are not perfect, but it gives us quite a bit of information with regard to human genetics, and there's also a lot of room for improvement to see how we could make the calcium handling more efficient, how we could make the mitochondrial bioenergetics more efficient, and so forth. And a lot of times when the postdocs show up in my lab, I just ask them, for the next 5 years, are you going to spend time working on this and trying to improve the system? Are you going to try to go back to your FVB mouse and just isolate the mouse neonatal cardiomyocytes and study them? And I would say that in the long run, this is probably going to give you more bang for the buck because there's still a lot of room for improvement, and you're working directly with the human samples. But again, this is a clinician talking here. So I want to give you some examples of what we've been doing with these iPS cells with disease modeling for drug discovery, for patient stratification, and also for clinical trial in a dish. Because of time, I won't touch upon the cell transplantation. I would say that we have a human ESL-derived cardiomyocyte program that was funded by CIRM, the California Institute of Regenerative Medicine, in which we're probably about a month away from filing IND with FDA to inject these human ESL-derived cardiomyocytes into ischemic cardiomyopathy patients. But that's a very clinical program, so I won't talk about this for this audience here. In terms of modeling disease, cardiovascular disease, there are a lot of diseases that you could study. For example, you could study cardiac channelopathies, you could study CPVT right here, you could study ARVD, you could study hypertrophic cardiomyopathy, you could study dilated cardiomyopathy. And again, we have access to many of these patients, and so right now with this model, you should be able to directly study the patients' cells instead of trying to create a mouse model of these right here. So I'll just give you a few examples, and I know some of the audience members are not clinicians, so just want to highlight, for example, DCM, dilated cardiomyopathy, most common diagnosis in patients who undergo heart transplant. Familial dilated cardiomyopathy is the most common genetic cause of cardiomyopathy, and with increasing use of DNA sequencing, about 35% of the patients with initial diagnosis of idiopathic are actually found to have familial dilated cardiomyopathy. About 6 years ago, we were referred this patient. He already had a heart transplant. His echo shows an ejection fraction about 20-25%. Turns out his father, uncle, and grandmother also has dilated cardiomyopathy. It runs in the family. We decided to do DNA sequencing. It came back as a troponin T with alternating the tryptophan switch. And the question that's being asked by our referring physician, as well as the patients themselves, are, hey, doc, I have this mutation. How is this mutation cause of this phenotype here? So you could, as I mentioned, you could just generate iPSC cardiomyocytes in an entire family. And in this case here, this is on a 64 multi-electrode array, and there's a chunk of embryo body, and it's beating, and you can see this is control normal patient. When you expose it to norepinephrine, the beating rate goes up, it stays up. This is dilated cardiomyopathy patients. When you expose it to high-dose norepinephrine, it goes up, and after 2 to 3 hours, it kind of poop out, meaning that patients with this particular mutation cannot tolerate the stress. You can give a low-dose norepinephrine for 7 days, and you can see control patient tolerated okay. Patients with this particular mutation, you can see after 7 days of stress, low dose of stress, the sarcomere kind of bursts and the cells, many of these cells die. So there are a lot of these assays that I won't go into details, but I think a lot of the stuff that we do in our lab is the validation of these assays that allows us to tease out the difference between control and disease at patients. But for this particular study, what we've shown is that compared to the healthy patients, the diseased patients had altered regulation of the calcium ion, decreased contractility, and abnormal distribution of the sarcomere alpha-actinin. We could treat it with beta blockers, for example, metoprolol, to improve the function of these cells. And we could also stress it by using norepinephrine that I showed you earlier. So that's one example. Another example is familial hypertrophic cardiomyopathy. This affects 1 in 500 people. You probably heard of a patient, young athletes in the football team, basketball team, who die all of a sudden playing basketball, playing football. This is what the cardiologist will be looking for if the patient survives, and what the coroner's office will be looking for if the patient dies. Very thick muscles, very different from the previous case here. Clinically, they have cardiac arrhythmia. They also have a systolic anterior motion of the mitral valve leaflet causing obstruction when the heart pumps. And so about 5 years ago, we were referred this family. The mother here has a hypertrophic cardiomyopathy, and this is her MRI. This is diastole, systole. You see systole when the heart contracts is essentially this LV, left ventricle cavity obliteration right here. And she had symptoms of palpitation. It turns out 2 of her kids also have the same hypertrophic heart. And by DNA sequencing, is a myosin heavy chain arginine to histidine switch. And she had 8 kids, and kid number 3 and number 8 are genotype positive, but phenotype negative, meaning that they haven't manifested the disease yet. And just like the previous patient family, we're being asked by our referring physician and also the patients, how does myosin heavy chain 7 arginine to histidine switch cause the patients to have hypertrophic heart? Again, you could create a mouse model, but probably 95% of the time, many of the mouse models don't manifest at the cardiovascular disease, so you're kind of stuck. So now you just go directly to the patient, get the blood, get the iPS cell, differentiate cardiomyocyte, and study them. And so in this case here, we're able to show that the myosin heavy chain 7 mutation causes increased intracellular calcium. The calcium handling defects leads to arrhythmia. There's activation of the INFAC signaling pathway leads to hypertrophy. You can exacerbate the hypertrophy by beta-adrenergic stimulation. You can block it by propranolol. You can also block the arrhythmia by lidocaine, mesillatine, venolisine. So now you have a platform that allows you to do drug screening in vitro. And I'll get into this drug screening aspect later on. A third example is the LV non-compaction. This accounts for 9% of our children with primary cardiomyopathies. This is the third most common cause of cardiomyopathy after dilated, after hypertrophic that I showed you earlier. clinically, these kids have holes in these hearts, what we call tuberculations, and they could present with dilated restrictive arrhythmia and thromboembolism as well. About 4 years ago, we were referred by our pediatric cardiology colleagues. This kid right here already had a heart transplant because of LV lung compaction. 2 siblings also have asymptomatic LVM lung compaction. Father has some type of dilated cardiomyopathy, unclear what. Another family with LV lung compaction. And we sequenced 2 families. Turns out both families have a TBX20 mutation. Again, how does a TBX20 mutation cause this particular phenotype? And over a span of about 2 years, 3 years, one of my former postdocs, faculty in Japan, Kazuki, was able to show that one of the key factors here is abnormal TGF-beta signaling in these patients that basically screws up the cellular proliferation, causing the phenotype. Again, just probably one mechanism out of many other mechanisms. So you could do this not just for the hypertrophic disease. You could do this for screening for adenovirus or Kawasaki virus-induced myocarditis. You could also do this to model hypertrophic versus dilated cardiomyopathy. You could do this to study Brugada syndrome. And you could do this model to understand by single-cell sequencing what are the different steps that are involved in cardiac differentiation as well. So I want to move on to how we do this for drug discovery. And this is an area of interest to me because, as many of you will know, it takes a lot of time, a lot of money to get a new drug developed. Typically, people will tell you $1.5 to $2 billion on average and 12 years. One of the major reasons for the inefficiency is because of the inaccuracy of the preclinical drug assays. You can have a drug that works beautifully in mouse, but actually don't work in humans. And then also cardiac toxicity is the #1 cause of drug withdrawal post-marketing. The simple logic is that if I give you a drug and you have a skin rash, I should just put some steroid cream on it. If I give you a drug, the next day you don't wake up, what happens? I'm going to get sued, right? Because, the patient dies from the cardiac arrhythmia, and you guys are well aware of these issues. So we've been interested in the cardiac toxicity because, as I mentioned, cancer and the heart are the 2 major diseases in the U.S. And so here the title says that is it possible to take a human iPSC-derived cardiomyocyte to recapitulate the predilection of breast cancer patients with doxorubicin-induced cardiac toxicity. So clinically, when patients have breast cancer, they get treated with doxorubicin. 10% of them will develop acute cardiac toxicity. About 20% of them will develop heart failure within a year. And then about 30% if they have 75 years old, doxorubicin and Herceptin. So this is the issue for the cardiologist, this issue of cardio-oncology. And here we're trying to say, is it possible to use iPSC to predict this? And so we have breast cancer patients, normal cardiac function. Some of them have doxorubicin-induced cardiac toxicity. We generate the iPSC, we expose it to doxorubicin. We set up these assays, contractility, calcium, metabolism, gene expression, apoptosis. And then this also becomes a screening platform for us to look for drugs that may be protective of this effect. We're trying to predict which one of these have toxicity and which one of these do not have toxicity. And shown here is 12 patients that we recruited. 4 of them are healthy, no breast cancer. 4 of them have breast cancer, received doxorubicin, nothing happened to them. 4 of them have breast cancer, received doxorubicin, they developed toxicity. You can see 31-year-old woman, her ejection fraction went from 70 down to 45. Another young woman, 40-year-old woman, her ejection fraction went from 77 down to 36. These are very young women, and likely they have other coronary artery disease, more likely that they develop the cardiac toxicity because of the doxorubicin. And the question is, how do you predict? And so here, if you compare the dox versus the dox-tox, remember these are the women who developed toxicity. I gave them 1 micromolar of doxorubicin. You will see the dox-tox patient has much more sarcomere disarray. 1 micromolar, the dox-tox patient had much more apoptosis. And 1 micromolar, the dox-tox patient had much more cessation of beating. And the same dose, there's more cell death. So this is very interesting because, when I was a cardiology fellow, we've been trying to look at GWAS study, genome-wide association study, to find out what SNP is associated with cardiac protection and what SNP is associated with cardiac toxicity. On the population level, that's fine because you could get p-values, but on the individual person level, it becomes very difficult because you can imagine I have a SNP that causes cardiac protection. And you may think I'm safe from chemotherapy, but then I may have 30 other SNPs that you're not aware of that causes cardiac toxicity. And so just by focusing on this, it gives you a wrong readout. Here, the cell is essentially like a mini chip. It encompasses all the DNA, all the RNA, all the protein, all the SNPs, and it's the aggregate of all the SNPs, what happens when the cell gets exposed to chemotherapy like doxorubicin. Besides doxorubicin, which, as I mentioned, causes about 9 to 10% cardiac toxicity, there are other chemos, for example, Herceptin, alkylating agents, small molecule tyrosine kinase inhibitors. These are very popular chemotherapy drugs, sunitinib, sorafenib, and so forth. And so many of these TKIs also cause cardiac toxicity. For example, it could cause heart failure, tachycardia, QT interval prolongation issues, congestive heart failure, and so forth right here. So we had a study in which we also showed that we could take human iPSL-derived cardiomyocyte and use high throughput screening and assess the tyrosine kinase inhibitor cardiac toxicity using this platform as well. And the idea is that we can, in this study here, we recruited 13 patients, generated iPSL, differentiated cardiomyocytes, exposed them to 21 most common tyrosine kinase inhibitors, and based on these, we're trying to find out which one of these TKIs are associated with cardiac toxicity and which one of these TKIs are not. In this case here, I already show you that doxorubicin is not safe, right? And if the safety index is less than 0.1, it's usually associated with quite a bit of toxicity. Very interestingly, vanditinib and nulitinib, both of them, easily we could pick up prolongation of action potential on the iPSLs. But interestingly, both of them were missed in the preclinical studies, and only when the drug was widely released did the FDA realize that these drugs can cause a QT interval prolongation. And so both of them right now have a black box warning that if you're going to take these medications, you should have your EKG checked routinely. So the idea is in the future, is it possible to use personalized iPSL for assessing cardiac toxicity? Patient get diagnosed with cancer, and you generate the iPSL cardiomyocyte, you expose them to these chemos. You're trying to find out, what chemo is safe and what chemo is not safe. You're trying to use this as a screening platform to develop additional chemo-protectant medications. I want to move on to how we use this for patient stratification. This is also another area that we get a lot of requests from our clinicians asking us to find out what's going on. And so this started with, I'm not sure if you have seen this in this audience here. This is David Feinberg, who used to be the CEO of Geisinger Health. Right now he moved to Google. Geisinger Health is probably one of the biggest healthcare systems in the Northeast. And back in May 2018, he declared that Geisinger Health is going to do DNA sequencing routinely on their patients for free, right? And well, you might think, well, it's free. Why is it they're doing that? But they're probably trying to acquire the genetic data of many of their patients so that they could use this data, partner with drug company, and get some licensing deal, and the drug company can access these genetic data. But on an individual person level, how useful for this? This is a rebuttal by another person, and he basically says, I just want to read this verbatim right here. Geisinger's rhetoric describing DNA sequencing misleads what the technology is capable of doing today. Likely in the near future, we are preventing disease from happening is inaccurate because few diseases have a single cause. Currently, this technology is an unfocused screening and creating anxiety and uncertainty. Well, the truth is probably somewhere in between, right? It's not as rosy as what Geisinger is thinking, and it's not as pessimistic as what this person is thinking. It's, really somewhere in between. And the other truth is that this is real time right now. It's happening real time. And I'll give you a couple examples. This is a 45-year-old man here. He's worried because his brother passed out and his uncle passed out. He's very worried now. And he shows up in our electrophysiology clinic, and he says, hey, doc, am I going to pass out? Well, it runs in the family. So our physician decided to do sequencing. It came back as a variant of unknown significance in KCNH2. when we ask the brother and the uncle, they want nothing to do with it. They don't want to get sequenced. So it happens quite often. A patient may be worried, but the family members want nothing to do with it. And so how do you adjudicate whether this VUS, variant of significance, is causing symptoms or not? Very difficult. You have to wait and wait and wait to see whether he developed the symptoms or whether there's additional literature published and saying that patients with this particular variant causes either normal disease phenotype or causes abnormal disease phenotype. Can you shorten the time right now? Because he's very worried, and can you shorten the time and give him a better information? So in this case here, we generated his iPS cells, and his iPS cell actually have a cardiac arrhythmia baseline. And then when we genome edit 2 copies of this variant in his iPS cell, we saw a worsening of the arrhythmia. And when we corrected it so that instead of plus minus, we make a plus plus, and the arrhythmia went away. And when we introduced the same variant into a normal cell line could be my cell line. And in fact, the postdocs had my iPS cells growing. And my iPS cell line started showing arrhythmia. Then based on these 4 steps, we used an iPS cells model. Again, this is not CLIA certified. We went back to our clinician and we said that most likely this is a pathogenic variant rather than a benign variant. So that's one example. Another example is this right here. I'm not sure if you guys have concierge clinic. We have concierge clinic at Stanford. Concierge clinic means that you have your regular medical insurance, but you want to pay additional money, and usually it's about $500, $600, $700 per month extra to your doctor, and you get 24/7 access to your doctor, and it's concierge clinic. And a lot of times, these are VIP patients, and in this case here, healthy 45, 46-year-old man, concierge clinic. He wants to get his DNA sequence, and it came back as a VUS in hypertrophic cardiomyopathy. Now, I showed you earlier hypertrophic cardiomyopathy is bad, and it came back as a likely pathogenic VUS. So how do you advise this patient who's otherwise healthy, shows up at your concierge clinic, asks for DNA sequencing, came back as a likely pathogenic VUS? How do you advise him? This is real time. This is not a made-up example. This is a real patient who shows up in our clinic. Or you could say, well, you're clinically fine. You don't have any symptoms. But he's very worried because his brother, his mother, and his daughter also has it. We could say, well, all of them are fine. We're just going to leave this alone. And you're going to come back next year. If you have palpitations, let us know. We're going to scan you with echo or MRI. But what if this guy who's a VIP, he flies from San Francisco to Frankfurt on a business trip, and long flight develop a deep venous thrombosis, DVT. The deep blood clot goes to the lung and causes pulmonary embolism, dies all of a sudden, and the coroner's office did not figure out it's a DVT-PE, pulmonary embolism. Young guy, the coronary office is going to write down what? Sudden cardiac death, right? I mean, otherwise, how did the patient die? And so sudden cardiac death in this guy's death certificate. What if the wife happens? Actually, the wife is a lawyer. What's going to happen next? You're going to get sued, right? Because this wife says, hey, doc, you sequenced my husband. It's a likely pathogenic hypertrophic cardiomyopathy, and you didn't do anything extra, and my husband died, right? This could happen. What if we want to practice defensive medicine? I want to practice defensive medicine means that I want to protect myself from getting sued. I'm going to order echo or MRI on this person. It looks fine. But the fact I order echo or MRI, does that cause him to be more worried or less worried? Probably more worried, right? Because he's going to think, hey, doc, why are you ordering all these tests? Echo, MRI, Holter, and all that stuff. And he's going to be more worried. And the next time he has a skip beat, remember, he's got a concierge, he's in the concierge clinic. Concierge clinic means he can call up his doctor anytime. So he's got a skip beat at 2 a.m., he's going to call you. And you have to answer that call because it's concierge clinic. And think about all the phone calls that you're going to get from this patient. So this is real time right now because it's happening. And so in this case here, this was also referred to us. And it turns out that when we generated his iPS, it looks fine. And when we genome edit to make a homozygous variant of this myosin light chain 3, it also looks fine. When we do a frame shift mutation, it looks fine as well. And when we introduce a well-known pathogenic variant here, myosin 19(3) CTG, in him, then we start seeing arrhythmia. So it's basically telling us that there's nothing wrong with our genome editing approach. And so in this case here, we went back. Again, this is not CLIA certified. This is a basic pure research. We went back to the clinician that we think it's just, instead of likely pathogenic variant, we actually think it's probably a benign variant. And you'll see in the era of precision medicine, you hear about all the time, really the Achilles heel of precision medicine, this issue of the variant of uncertain significance. Because it renders very difficult clinical interpretation, risk assessment challenges, personal and psychosocial impact, and high emotional stress. And in the future, you will see many academic labs and also companies using iPSLs and genome editing and genome sequencing to adjudicate what's going on with some of these variants here. Lastly, I want to show you how we could probably do this in a clinical trial in a dish model. And this is Takeda back in 2015. 2 years after Shinya Yamanaka won the Nobel Prize, he gave Dr. Yamanaka, the Takeda company gave Dr. Yamanaka $270 million over 10 years. And the goal is use the iPSL platform to come up with drugs. But remember, I mean, Dr. Yamanaka, he's almost like a demigod in Japan, right? So he's probably, people know his name more than the prime minister's name. And so, but a lot of money, and you'll see in 2017, right here, this is, they've already had hits. In this case here, they recruited patients with fibrodysplasia ossificans progressiva. It's a bone disease, very rare, so there's no good treatment for these patients. And they recruited these patients, generated the iPSL, differentiated the bone cell, set up these chemical library screening, and find hits, and then show that the hits are safe in animal models, and then they're going back to phase 1 clinical trial, giving it to these patients. So think about the speed of this platform now in terms of screening for drugs and do a phase 1 clinical trial. And so this is what they're proposing, right? In the future, if you have a hit, if you have a drug, instead of testing clinical trials, you don't know which patient is going to improve, which one is not. In reality, for most clinical trials, if you give a drug, there's probably, 5 patients will improve, the other 95 will not. But the problem is the other 95 drowns the signal, so your p-value becomes nothing. And is it possible for you to a priori predict which one of the 5 is going to improve and give it to them, right? Otherwise, you have to become a very big trial, a very expensive trial. Here, this is what the platform is, generate the iPSLs and test the iPSL, find out who improves and who doesn't improve, and use this as a way to improve your hit rate and also have a lower false positive, false negative rate. So we've been interested in this model, and for example, one is responsiveness prediction. And so a while back, we did a study in which the title here says you could do transcriptomic profiling of patient-specific human iPSL cardiomyocyte to predict individual drug safety and efficacy responses in vitro. Granted, this is a very crude experiment, but I think in the future, it'll be more and more refined, sophisticated. So essentially, we took patients, generated iPSL cardiomyocyte, exposed them to rosiglitazone and tacrolimus. These are 2 known drugs that can cause cardiac toxicity. And based on RNA sequencing, we're trying to predict which one of the patients will have issues and which one of the patients will not have issues here. And, the holy grail is that 20 years from now, hypothetically, I'm 70 years old, and I need a medication for my Alzheimer. And how do I know which medication works? There's probably 20 or 30 Alzheimer medications out there. 20 years from now, you guys should be able to develop a platform, take my brain cells in the dish, test it with Alzheimer drugs 1 to 30, and tell me number 28 is the one to go, right? So this is the holy grail of what we want to achieve in the future. The other concept is this concept of ethnic groups, meaning that the way we respond to drugs, is it going to be the same among all of us? Probably not, because of different ethnic makeups, right? And how I respond to drug is probably different from what stage you will respond to drug, different from what another person will respond to drug based on our ethnic makeup. I'll just explain one idea right here. So this is aldehyde dehydrogenase 2 genetic polymorphism. this genetic polymorphism occurs in 8% of the world population. 36% of East Asians. It causes alcohol flush reaction, nausea, tachycardia, headaches. And I happen to be missing this enzyme, so when I drank a glass, my heart rate will probably go from baseline 60 to 120, 130. So it's a good gene enzyme to be missing because, like yesterday, I didn't exercise and I just drank 2 glasses and my heart rate was up for about an hour. So that was my exercise for the day. But it turns out we treat alcoholics with the same enzyme. We treat alcoholics with the same with drug antibiotics, which block the same enzyme. So alcoholics will feel the same way I do. Now I'm heterozygous because I know my dad can drink all he can. My mom cannot drink, so I can still drink. But if you block this enzyme completely, the alcoholics will feel very bad when they take antibiotics. Now, this enzyme has also been associated with increased risk of coronary artery disease, heart attack, hypertension, cancer, and type 2 diabetes. And so this is no joke. Clinically, this is well known. For example, increased risk factor for myocardial infarction in Japanese men, Korean men, Han Chinese. So I, as a lab PI, saw this data, and this becomes high priority, right? I don't have it. I want to understand what's going on. So I assigned postdoc to work on it. It turns out none of my postdocs from East Asia, they want to work on it, but I had a German postdoc who decided to work on it. And she's now at the faculty in Germany right now. And so we recruited 10 Stanford undergrads who are East Asians. 5 of them are wild type, means these kids can drink, no tachycardia, no flushing. 5 of them are heterozygous, meaning that they get tachycardia and facial flushing. And we generated the iPSL cardiomyocyte. We exposed them to hypoxia to simulate cell death, right? During a heart attack, there will be hypoxia. And then you'll see the heterozygous patient, they have much more apoptosis compared to the wild-type patients right here. So to make a very long story short, what we think is happening is that if you're heterozygous or homozygous mutant, after a heart attack, you have tons of ROS that gets activated. You have a hard time detoxifying ROS, and you end up with much more cellular damage compared to somebody who protected wild type from this. And so this is one example of using race-specific iPSL to show major ethnic differences. And so I showed the example of East Asians, but what about other groups? Why is it African Americans have more essential hypertension, right? Why is it Hispanics have much more diabetic vasculopathy? And why is it South Asians, normal BMI, they have much more metabolic syndrome, right? So instead of studying mouse, now you could just go to your clinic, recruit these patients, study them using the iPSL. In this case, we would use the iPSL endothelial cell model to find out what's going on. So at Stanford, what we've done is we've created a biobank of about 1,000 patients from different cardiovascular history, ethnicity, sex, and also isogenic lines using CRISPR genome editing. We're routinely performing DNA sequencing on the iPSL, so we understand the genetics, and also doing RNA sequencing on the iPSL cardiomyocytes, so the iPSL endothelial cells, before and after some kind of drug exposure, so we understand what the transcriptomic profile look like when they get exposed to a drug. We link it to the PharmGK database, so we want to understand how human genetic variation impacts the drug response. For these patients, we have the clinical database as well, so as shown here. We're working with CERM and also NIH and the biobanking, and also with the FDA and drug safety testing. And we've also established a very robust sharing plan with many investigators that we're happy to share with the groups here. So this shows the patients that we've recruited, about 1,300 patients. You can see ARVD, Bugada, CPVT, DCM, HCM, long QT, alveolar compaction, single ventricle tetralogy, below transposition of great artery, short QT, and so forth. We've generated iPSLs from almost 1,000 of these patients here. And we've also sent out more than 2,200 vials of these iPSLs to more than 220 investigators. And again, if you guys are interested, we're happy to share these cells with you because, only by having more and more people working on this will the science advance. And so in summary, I'm a clinical cardiologist. I still see patients, although I collaborate a lot with my clinical colleagues. I ask them to refer interesting patients that they're not sure what's going on, and then remember, for most clinical groups right here, we have a lot of patients. We have good clinical phenotype. Genomics is easy because you can send it out, $850, you get the DNA sequence. What comes back is difficult. How do you interpret the data? How do you test it? So now you have a test bed for these three by using patient-specific iPSL. You can add or delete genes by genome editing. And so with that, I want to thank the postdocs in my lab, their funding support, the graduate student in my lab, their funding support, and the instructors in the lab, their funding support, cardiology fellows in my lab, the funding support, my former postdoc who I mentioned their work, collaborators at Stanford, collaborators outside of Stanford. And if you're interested with these cells, we're happy to share, and the funding support from the NIH and AHA and the CERN. And then lastly, for those of you who's interested in drug discovery, each year at Stanford we run a drug discovery symposium that the Cardiovascular Institute runs, and this year will be April 22nd, 23rd, and you can see here we have basically the CEOs and CSOs of major companies, and the goal is to have 2 days of very intimate setting in which we talk about how do we advance drug discovery from the academia, the government, the industry, the FDA standpoint. And with that, thank you very much for your attention. I'll be happy to take any questions. Particular class of molecules. I would say I think for those of you who work with it, actually the iPSL, the channels are pretty good, but I think the mitochondria is weak. The T-tubules are kind of weak, although I think Godana's group at Columbia has been using these engineered heart tissues to get more mature cells so that there's a T-tubules. I think you'll see a lot of 3D, generation of 3D to get mature cardiomyocytes, and we're certainly working on that. Although keep in mind that from a drug screening standpoint, from a drug company standpoint, if you have 3D, it's going to slow things down, increase the cost, and the technicians they have in the company will have a hard time generating it. So I think we should, in my opinion, we should pursue both simultaneously, meaning academia try to pursue 3D, try to make it better and cheaper. At the same time, I still think there's value in using 2D, and if there's some kind of chemicals that you could screen, some kind of genetic modification so that the tubules or whatever channel or gene of your interest can get upregulated, and then use that for your drug screening so that the big pharma can use it much easier. So that's probably the best answer I can give you. You have to pursue both. I don't believe that 3D is the only way to go because for drug company application, this will become very difficult. Yeah. Oh, yes, John. Yeah, so I think Stacy and some of you guys are involved in the CBAC initiative. We're involved in the CBAC initiative. I think a lot of it is based on, the CEO level of drug companies, they don't know what's going on. And when you go down to basically the scientists and so forth, many of the scientists are not trained in this technology, right? And so it takes a generation of some of these scientists to retire or to learn this new technique. If I'm a scientist, I'm 55 years old, and I've been trained in hex cells and trill cells, I say, well, what's the point of using this? And I stick with the same thing, right? But then you'll see that some of the companies start to hire the new generation of senior scientists in their company who are trained in iPSLs, and they're starting to adopt this. And we've certainly, I can tell in the Bay Area, many of our postdocs who decide not to go to academia get poached. And so I was telling the graduate students today, that, of the 5 postdocs that I had last year who left, one of them went to UIC, University of Illinois Chicago. 2 of them went to University of Arizona. 1 of them went to Amgen. The other one went to Merck, right? Because they're posting these, and it takes time for them to develop. And so I think Norman Stockbridge at the FDA, he's very interested in this particular model. And in my opinion, it's probably a matter of time before people switch drug testing to this right here. Yeah. Yes, Greg. Yeah. 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 So those are good questions. Just remember the cells that we generate, think of it this way. The cells that we generate resemble the cells that you were born with. Right? Resemble the cells that you were born with. So think of it this way, that hypothetically, you and I are identical twins. You and I are identical twins. You exercise every day. I got divorced. I got depressed. I got and I eat a hamburger diet. I get a massive heart attack. And the iPSL will look the same for you and I, because iPSL will not have been able to predict that I did that to my body. So think about these as cells that you were born with, and what is the susceptibility of your cell when you were born with. And so a common example would be, well, since we can't predict, then the cells are no good. Well, but you could stress it. You could stress it, and I'll give you one example of a project that we have. Hypothetically, mother is fine. Father is diabetic. Father is diabetic, family history of diabetes. Mother is fine. Kid born. What's the first question the mother asks you? What's going to happen to my daughter? Is she going to be diabetic, right? Because my husband is a diabetic, family history. I'm fine, my daughter. And so in that case, we have studies in which we generate the iPSL endothelial cells, and we expose it to glucose and insulin to show that, and then we do a whole bunch of assays compared to the mother, and we show that these guys, the father side, whatever gene X gets activated, much, much higher in response to stress compared to the mother who's fine. When we generated the daughter's iPSL-EC, if you gave it the same challenge, if hers looked like the same as the father, am I confident enough to make the call and say that the daughter will be genetically susceptible, is genetically susceptible just like the father? We have these studies going on. The other studies that we have is exposure studies. For example, yes, we cannot model smoking. We cannot model, somebody taking marijuana, right? But you could, we cannot predict that you'll be a smoker and I'm not a smoker and so forth. But you can actually take these iPSL-ECs and expose them to nicotine or expose them to e-cigarettes and see what's going on upon these endothelial cells, upon exposure to these some of the toxins. So I would say that there are some limitations. You just have to know what the limitations are. And there are also ways for you to model that. And then the last thing I would say is that we have studies in which we've generated iPS cells from patients, and we look at 2 different clones. And from these 2 different clones, we look at passage 15 versus passage 30, and to see how they respond to drugs. Because the question is, the clonal variation, do they respond differently? The passage number, do they respond differently? Because it's no good if passage 15 and passage 30 look very different, or clone 1 and clone 2 look very different. And we've done it with 6 different patients, and we can show that most of the variation is actually for a genetic background. And if you look at the same patient, if you look at me, clone 1, clone 2, passage 15 and 30, my response would be very, very different from your response. Yeah. Yeah, so we do a lot of genome editing with different kind of SNPs, and also remember these are single cell model, but it doesn't prevent you from doing whole engineered hard tissue model, so that your cells are mixed with fibroblasts, mixed with endothelial cells to give a better representation of what's going on. And also, some of the things that you may be surprised is that traditionally, I'll give you one example that I didn't show. We have data. Traditionally, we think of, again, our lab works mostly with dilated hypertrophic cardiomyopathy. Traditionally, we think of somebody with a hypertrophic cardiomyopathy as for example, as a mutation in a sarcomere. And therefore, the mutation in sarcomere causes these cells to go big, hypertrophic, or just go poop out because of dilated cardiomyopathy. That's what we're so focused on. But what if I show you that we now have data in which using this iPSL technique, if I take iPSL cardiomyocyte and from somebody with hypertrophic cardiomyopathy, co-culture with fibroblasts, iPSL fibroblasts, and I sequence this guy and I show activation of inflammatory genes. And then I genome edit this guy so that it no longer has the hypertrophic gene, co-culture with the same fibroblasts, and I show no activation of inflammatory genes. So now, in an EHT model or in a co-culture system, you can now start teaching out what is the crosstalk between iPSL cardiomyocyte that carries the mutation and what is its influence on neighboring cells based on using single-cell sequencing platform. These are the kind of technology that was never possible in the before. But now with iPSL, with single-cell sequencing, you can now start teaching out the crosstalk issues that before you cannot recapitulate in just a single-cell iPSL cardiomyocyte. Yeah, so very good question. I think what people have done is they go back to the patients who already manifested the disease, and then they study it, and they try to find out what's going on. But what you're asking is, how well is this a prediction? I think there's a lot of issues, right? So, I mean, it can predict, but at the end of the day, it just gives you a better, in my opinion, it gives you a better readout than the DNA sequencing, because DNA sequencing, you're not sure whether the modifiers are, whether other variants can cause an issue. Here, you're encapsulating everything into a cellular readout. Ideally, you want a human readout, but you can't get a human clone. And, next step is the human organ, but I can't get your human organ. Next step is the tissue, but I can't get the tissue. And I have a DNA. Everybody can get the DNA, but then I don't know how good that DNA is. Here, cellular readout is probably the next best thing that we have. I think other people, a lot of groups in the cardiology groups, for example, they've taken, for example, patients in the case of arrhythmia setting. I'll just give one example. There's this person, Jean-Sébastien Hulot. He's at France, and he published a paper in eLife in which he took about 20 patients, and these 20 patients, he generated iPSL cardiomyocyte. And he was able to get the IRB approved that these 20 patients, all of them got sotalol, which is a beta blocker, a form of beta blocker. And iPSL, all of them also got sotalol. And you can see that there's a correlation. Extreme ends look better. In between, it's much difficult, but extreme ends, it looks a very, very good correlation. You'll probably see more and more examples of that. Why it's difficult to do is because it costs a lot of money. For him to do that study, at least $1 million. Yeah. Thank you. Yeah. Mm-hmm.